Welcome to a 1-hour Pallium Project archival podcast of a professional development event. The views presented in this session are those of our expert guests and participants from across Canada. In this podcast, Jackie Peden, an advanced practice nurse in hospice palliative care, interviews Dr. Romayne Gallagher, head of the Division of Residential Care for Providence Health in Vancouver. This session is entitled Teambuilding, Working Effectively with Local Physicians.
It's great having you speak with us today, Romayne. Can you define a team? What is a team?
Well, a team, I have a specific definition that I can give to you, and it's a group with a specific task or tasks, the accomplishment of which requires the interdependent and collaborating efforts of its members. So it sounds like a mission statement, I suppose, but really, in palliative care, we don't have a specific team, and of course those of you who come from smaller sites will say, well, we're never going to have a palliative care team. So we have to form teams around the patient and family when we need them. It's not as though we can have a dedicated team for palliative care in every center. And, you know, in really small centers, could be you and the physician are it. You're the team for everything. And so really the team focuses around the patient and around the family. And I think one of the things that we can do is really make a difference to patients and families by thinking of ourselves as teams, because really end-of-life care often has a lot of major discontinuities in clinical relationships, so particularly when people have cancer and the oncologist says, well, I don't have any more to offer to you, or the cardiologist says, you know, I don't need to see you anymore. And people really often feel abandoned and let down. And having a sort of a team that's there to catch them and to pick up the pieces is extremely important.
Do you consider the patient and family part of the team?
Very much so. And in fact, they're the reason for the team, but I think they also should be considered as team members. And I think we're going to discuss how to include them later on, right?
Okay. I just wanted to clarify that. I think that it was insightful that you said that in some of the smaller communities, you won't have access to a multidisciplinary team, which we often the literature says is important in palliative care. But you sort of hadn't mentioned very much about the patient and family, so I just wanted to clarify that.
Sure. Okay.
Can you tell me what the role of the team is?
Well, the role of the team, I would say, is to care for and support the patient and family through the illness. And so the team is about the family and about the patient, and not about the healthcare providers, as we'll discuss later on. The other purpose of the team is to coordinate care and help navigate the patient and family through the healthcare system. And I think this is a major problem for people today, is trying to figure out how to negotiate this thing. The other thing I think which is a key part of the team is to support each other. The healthcare providers need to support each other in the difficult work of caring for people and family at the end of life. And this is where, you know, I think it's where we help each other. And, you know, I mentioned before that the team is not about healthcare providers, but in this sense we do support each other and help each other deal with issues. Can I talk about some characteristics of an effective team?
Sure, go ahead.
And this is from an article written by Ina Cummings, I believe, who is from Nova Scotia, I believe, which dates back to 1998 from the Oxford Textbook of Palliative Medicine. She was talking about characteristics of effective teams. And her points were that as a whole, a team is greater than the sum of the individual members. In other words, that shared minds work better than individual minds. That the leadership role is shared. And, you know, probably we kind of know this. Sometimes someone will take the role on an issue or a role on a patient where, you know, other times they might not be the leader. And we need to be flexible in our professional roles because, you know, some people have a lot of problem in saying, well, I'm the physician, I'm the one who's ultimately responsible for this, and how can I share my professional responsibility? But, you know, a confident team knows and trusts each other and does have flexible professional roles. The team is interdependent, so the whole team succeeds or the whole team fails. and it's not about a single individual. There also should be a sense of fun and belonging, and I know in healthcare these days a lot of people would say that it's very difficult to find a sense of fun and belonging, and I think it's been in teams where you have good relationships that you've actually helped each other survive through increasing workloads, fewer resources, more stress, etc., and I think it's so important. It's also, I think, key that members share their vulnerabilities as well as their strengths, right? So that if someone's upset about something or someone's feeling like they failed on a particular issue, then they can talk about that. And I can well remember, actually, if I can digress and tell a story, going to having a group of physicians there and being so pleased that one of them could stand up and say, well, I'm going to lead off the discussion by talking about a time when I feel I really failed to look after a patient, and was able to discuss how he felt he had failed. Actually, I think he succeeded because he never abandoned the patient. It was just difficult symptom management. But the ability to sort of share your vulnerabilities. The other thing is the ability to deal with disagreements and anger in a constructive manner, and we'll talk about that a bit later. And also, most importantly, that the team helps each other to grow professionally and that we share learning. So that's it, and that's where her thoughts on an effective team.
I liked what she said about shared minds. It sort of really fits. I was fortunate that when I worked on the palliative care team, on a palliative care team in home care, and so we had a team of people who that's all we did was provide palliative care. And we did go out of our way to make sure that we supported one another. Fridays was always popcorn day. We would share bringing in popcorn. I think I ate more than anything at that team in our team meeting. So I remember that
for the
really,
dental bills.
Right. I just remember a really good sense of team cohesiveness and support, and that's sort of what helps me get through doing the work that I did.
Yes, I know we found often the ward I worked on, if we'd had a series of difficult deaths, was to sort of declare a coffee afternoon and someone would bake some cake and stuff like that. And oftentimes, and I so well remember a nurse who came to one of this saying, and she was a new nurse, and saying, oh, I felt kind of bad because I was crying with Mrs. H, let's say, who had died. And she was telling me, about how difficult her illness would be, and I started to cry. Was that unprofessional? And, we were able to express to her the fact that we thought she was behaving in a real human way and probably gave a huge amount of comfort to Mrs. H. And I sort of think, gee, how would, if we hadn't have had that opportunity to talk about that, would that have perhaps shut down someone who could really grow as a person and share the journey with people?
Why is a team approach to care important?
We actually have research evidence from the ICU that the degree of coordination of care, in other words, how well the team functions, is a key predictor of the survival of patients. So in palliative care, I think team function is a key predictor of quality of life of the patient and family, and also the quality of the death experience for loved ones. Because I think we've all heard that nebulous figure that they quote, death of one person dramatically affects 5 people. I don't know where that came from. But we are very mindful of the fact that other people will live their lives remembering this experience. And I think the team is a key determinant of how that goes. The other reason for team approach is some people will have a different rapport with the patient and family. And I always remember a lady who was dying of cancer, and she was a nurse, and some people say, healthcare professionals can make the worst patients, right? And this lady was very interesting because she could talk really well with the nurse, but wouldn't really speak to me or the chaplain. And so we found it was great because if we felt that things weren't going well, we'd just say, well, she'll talk to you, you go ahead. And that was great because that way we were able to provide her with a good death and be helpful to her family. The other thing is we do learn from each other, and I've learned a tremendous amount working with other healthcare professionals and working and learning from the patient and family as well. The other thing is we share successes and failures. And, I think we probably don't think as much about the successes as we do about our difficult families. And I wouldn't call them failures, but you know what I mean. When the team, sometimes team members are able to see things that we can't. And I hope you don't mind, I'll tell another story. I remember this fascinating elderly lady who had her middle-aged son living with her, and I think, in fact, this fellow had a degree of mental handicap that we didn't quite appreciate. And he was meeting with a social worker and was behaving a little strangely, and he pulled out his gun registration card and showed it to the social worker and said, "See what I can do?" And he showed her this, and of course she came back to us saying, "Oh my God, this guy, he's kind of threatening us with his showing us his gun card, and was quite concerned that this might get out of hand." So we tried to not keep that in mind too much, and didn't request any bulletproof vests be sent to the ward or anything like that. We talked to him a little bit more and realized eventually that what he was trying to show us was not that he was threatening us, but that he was such a responsible person that the government trusted him to have a gun.
Right.
And so, but the rest of the team was able to figure this out, that it wasn't a threat. It was perhaps a person it was his way of showing us that he was responsible. The other thing that I think is so key about a team approach is that, we're trying to provide whole person care. In other words, we're trying to see someone as being a physical, psychological, and spiritual being. And as Balfour Mount, one of our fathers of palliative care in Canada, says, to give whole person care, it takes a whole person to do this. And I think all of us realize, right, that we bring our own problems, our own issues and experiences and judgments into the situation, and therefore it's really not possible for us to meet all the needs of a person who is dying in their family. We can't be all things to a patient and family. And that sometimes others can help us out with that. And, I'm thinking particularly of, I've worked with colleagues who may have had an experience of substance abuse in their family. And whether they realize it or not, sometimes they bring some resentment towards that. So when you're trying to work with somebody with substance abuse, things might come out that they don't even realize, right? And it's about what happened to them. And, the team can help out with that and sort of not only buffer that, but help that person to understand. I think this is where we can together provide whole person care. I also think if you try and do it alone, it's a recipe for burnout, professional burnout, and I think that's why a team helps us survive longer.
Good. Yeah, that makes sense to me. So let's talk now about the patient and the family. How can you ensure that they are part of the team?
I first think it's an attitude, right? That you first have to see that you're there to meet the needs of the patient and family. And I think this really gets put to the test when you have a family, say, who has different needs from most families. And for example, I'm thinking of a lady who was in her 30s, and she had a 5-year-old boy, and she was dying of bowel cancer, and she wanted to live to Christmas. This was August. She wanted to live to Christmas, which is a completely reasonable thing, and actually wanted us to do absolutely everything, and wanted TPM, total parenteral nutrition. And, some people would say, whoa, wait a minute, that's, inappropriate to give that to a person who's dying, But it was a challenge for us to sort of say, well, wait a minute, if we were, we're trying to meet her needs, she would desperately like to live as long as possible to spend more time with her little boy and her husband. And, how can we help her meet those needs? And so, we were able to, she was going back to a small community, and we were able to set up TPN through the local hospital. And, she was able to live longer. We also knew that medically she could tolerate it. It wasn't as though we were offering We had someone who was 90 asking for TPN, and we knew that wouldn't help them to live longer. We knew in this case it actually would help her to live longer and spend more time. So that was an example of where, we had to sort of say, well, maybe this is appropriate for this person.
Mm-hmm.
Another example of that, I think, that comes up often is those patients who appear to be denying that they're dying. And I just recently dealt with an older lady who was a physician and who appeared to be denying that she was dying and, was just sort of saying, I must find more treatment. I'm sure I can live. I'm sure I can get a cure. And this was really worrying the home care nurses because they felt that, her death was not going to go well. She wasn't thinking about two things. And so, how could we meet her needs? And what we ended up working out with her is saying, look, we know, it's possible to drive down two roads at once. Let's hope for the best, but prepare for the worst. And so I wouldn't have called it the worst, but preparing for the worst was making arrangements like, where did she want to die? Who did she want to be there? Talking about DNR, things like that. And then hoping for the best was her ongoing look for, looking for a cure. And that worked out quite well for her. I think we also need to include the patient and family in the meetings. And particularly, I find I've seen some meetings where healthcare providers get the family in there and then they just sort of they have a monologue of the healthcare providers reporting on the progress and the discharge plans. And I think it's much better if we start out and say, well, to the patient and family, what do you feel is happening? How are things going? What are your concerns? And I think that first that helps you find out the language that the family understands, right? And I don't mean language in the sense of French versus Cantonese. I mean the slang terms that they refer to bodily functions and, do they call it cancer or do they not call it cancer? Do they really understand that their heart is failing? These kind of things. I also think that if we want to make a patient family part of the team, we need to be culturally competent in the way we deal with a patient and family. For example, say you've got a Filipino patient who designates eldest son as major decision maker and wishes all information to be given to the son. Well, if we don't respect that, we're not really including them as part of the team. And I find some people still, sort of say, but we have to let the patient know, when we're kind of learning about different cultures and learning that, in fact, the patient wishes not to know and wishes their son to make all the decisions. So it's very important that we respect that as a way of including the family. And I want to add one more thing, Jackie, because I'm thinking that when I say the needs of the patient and family are number one, yes, but the needs of the team members also need to be respected. For example, I had a patient he had a bone destroyed by cancer, and the cancer was in his arm, and he just wanted the surgeon to fix it even if it killed him. And the surgeon refused, and he was very angry at the surgeon. And I had, to explain to him that the surgeon has some rights and, has some concerns too. He doesn't want to be part of his death. He doesn't want to do something that he knows is going to kill that person. And that the team also has feelings and has responsibilities.
So can you talk about some of the challenges of working within a team?
Right. Well, this is where we get to the issue of different personalities. And I think, different personalities can enhance a team if we use the energy cooperatively. And I think, but if it becomes uncooperative, they can really poison a team and make life miserable. And thinking back on all the jobs I've had, it's never been the work, it's always been the people. If the job turns out to be a disaster, it's always the people, never the work. Mm-hmm. The other thing I think we need to realize is that disagreement doesn't equal conflict, right? Because disagreement is a difference in ideas, but we don't get emotional about it. Conflict is when the disagreement is elevated to the level of emotional involvement, and that's where it really undermines the team. Now, if you have fun on the internet, you can look up things like the Myers-Briggs personality type indicator and check yourself out, because it's interesting in that you can see, like, what kind of a person am I? And it looks at people in terms of attention and energy focus. You know, are you an extrovert or an introvert? And an extrovert is the person who is spontaneous, can be talkative, etc. Introvert is the kind of person who just generally sits through a meeting, doesn't say very much, but then after has a heck of a lot to say. And then, you know, how do you make decisions? And do you base it on logical, analytical things, or do you base it on feeling and emotional? And are you a structured or ordered person, or a flexible, go-with-the-flow person? And these kind of things make a huge difference, and I think sometimes understanding how each other works can be helpful. For example, if you've got someone who's kind of quiet and doesn't say very much, they might have some really good things to contribute, but they probably need some warning. You know, they can't sort of spontaneously have a meeting and sit down and talk it all out. They need to think a little bit first. And, you know, the people who tend to shoot from the hip and be intuitive, I think it's the ready, fire people, as opposed to the detailed people who evaluate and ponder everything. They're called the ready, aim people. And, you know, how those people can work well together because they save the person from just starting off in the wrong direction, you know, the sort of the go-get-it person without thinking. Mm-hmm. Whereas the person who tends to be intuitive and go for it can help the person who's stuck making decisions. So we can work with personalities that way. The other challenge, I think, is that to realize that the team leader doesn't equal the decision maker. And although a team may need a leader who, you know, who's one that kind of takes the initiative, schedules and plans meetings, this person isn't always making the decisions. And we need to sort of distribute the decisions amongst the team or make a team decision together. The other problem that does tend to come up is that sometimes individuals can use the team to kind of take responsibility for individual things that they should have done. And, you know, a healthcare provider must not use the team to avoid responsibility. So we have our individual responsibilities, but we also have team responsibilities as well. And I think we probably, Jackie, want to move on, and we're going to talk about the issues around physicians, right?
I think that's what everybody is sort of waiting for.
Yeah.
So what are some strategies? That's what we wanted to talk about, was strategies that nurses can use to work effectively with physicians.
Well, and I really thought a lot about this one because it is difficult, and I think there's no denying that the way our healthcare was structured, there was a definite power differential, and this makes it really difficult. And I think also there are different personality types, and I think physicians used to be chosen to be, you know, sort of individual decision makers that had to make a decision, get on with it, you know. And in a way, this has backfired. And I think things are changing now. The newer medical students and graduating physicians I see are taught that they are part of the team. But I think we need to acknowledge that we can't immediately walk away from that power differential with older physicians who maybe don't understand that. I want to talk about the issue, particularly when a nurse is phoning a physician for an order, because I think, would you say, Jackie, that this tends to be an area of frustration for nurses?
Yes, definitely.
And when, say, a home care nurse is phoning for an order, a physician gives an order to a nurse, and the physician must take responsibility for that order, and really they're accepting liability for another discipline's work. So in order to do this, the physician must trust the nurse's professional skills in assessing the patient, right? Mm-hmm. And I think some physicians take this responsibility more serious than others. In other words, some physicians will say, sure, do whatever you want, or say to the nurse, what do you think I should do? Whereas others will say, nope, I'll have to come and see the patient myself. And, you know, how to get around those issues. I think one of the best ways, though, is in a relationship that's going to be based on trust. I think if you can demonstrate that you've done the proper assessment of the patient, you'll show the physician that they are able to trust your professional work. So, For example, a phone call where you might say, well, Mrs. B is having a lot more pain over the last few days, and I think we need to increase her morphine. Can we increase it to 50 milligrams sub-Q Q4? That gives an opinion and some information, but it doesn't show that you've assessed it. So if you sort of said, here's an example of what might work a bit better. Mrs. B has neuropathic pain radiating down her left leg. Earlier this week, the pain was 3 out of 10, and she was comfortable with that. Now, the same pain is escalated to 7 out of 10. She's currently using 35 milligrams sub-Q Q4 hours and 4 breakthroughs of 10 milligrams yesterday, and that still didn't seem to reduce her pain. It was still 7 out of 10. I can't think of any other reasons. There doesn't seem to be anything else responsible for the increased pain. She's not changed any medications, and she is really concerned that the pain's getting unbearable. Can we increase the dose to 50 milligrams Q4 hour with a breakthrough of 30 Q1 hour PRN? So you see, you're providing information that backs up your assessment, and you're showing the physician that you've kind of done your work, right? And the first example where you just sort of skip the assessment and the information part, you still had done your work. It's just that the physician was not clear. And when the physician gets to know you, often they'll say, oh, yeah, it's so-and-so calling me. I know they've done it. I'll go with it. But I think to have that assessment down is quite key. So I think if you're, say, assessing a pain, if you know where the pain is, how the patient describes it. I take calls on a 1-800 line in BC and the Yukon, and I find the thing that's often missed when I'm speaking with healthcare providers is, what's the pain like for the patient? And that's very helpful in deciding whether this is nerve pain or, non-nerve pain or whatever. So it's very helpful to know that. I think also using the scale to measure pain is very helpful, to know the medications and to know how many PRN doses have been used. I also think that it's helpful to know how much that the pain is affecting the patient, because I think this will give weight to the need for medication. Because if you say, well, Mrs. B's pain is 7 out of 10 and she can't get out of bed anymore, that adds a lot of extra weight to it, right? And I think to have suggestions for what to do. Now, so I know that many nurses will phone me on the 1-800 line before they phone the doctor saying, here's the situation, have you got any suggestions? Some healthcare authorities, the Interior Health Authority in British Columbia has, and they're actually online, but I think they have symptom management guidelines, and what they will do is often send these, fax the symptom management guidelines to the physicians. Now, I suggest, and let's go back to that issue about faxing the symptom. They fax the guidelines, but they also can fax the symptom assessment sheet. And I've seen these sheets, and they sort of provide a template for assessment, like where's the pain, what's the level of it, what are they currently taking. And so some nurses find that if they fill out the assessment sheet and fax it, and then say, going to call you in a couple of hours to get a new order. I know it's a couple more minutes of work, maybe more, but oftentimes then the physician says, wow, they've really done their stuff. They've got a record of it. And by the time you call, they're ready to give you the order that you need. And many people will do that, and this same health authority with the symptom assessment sheet will also fax the guidelines too as sort of backup. So how about if we talk about if you phone in, give the physician an order and they say no?
That's what I was thinking. Or you phone in and they give you an order like Demerol because they don't have a good understanding of medications that are used, of analgesics that are used. What do you do then?
Well, and I think I was looking in the nursing literature yesterday and looking about, dealing with conflict. And a lot of these articles said that nurses tend as a group to be conflict avoidant. So what happens is they kind of say, oh, okay, hang up, and then feel really frustrated, right? And then sort of say, now what the hell am I going to do? Because I've got a patient that, is suffering, and I feel like the doctor just hasn't recognized the problem. So I've got some strategies that I hope will help with this. Now, what about if the physician says, no, I don't think we should increase the dose? How about trying something like, well, I'm concerned that Mrs. B will be in more pain and will be calling, I'd like to say, we'll be calling you later today, but maybe we'll be calling us later today in more pain if we don't get this under control. Can you suggest a solution to this? And, to sort of say, I'm concerned, or for example, I'm concerned that Mrs. B, she's not able to get out of bed with the pain, and that, you may be finding that she's going to want to be admitted to hospital. Can you suggest a solution? The other thing that you can do is sort of say, okay, both this physician and I want this patient to be comfortable. And so what you could do is say, well, Dr. So-and-so, I know we both want her to be comfortable, and she's telling me that she's not comfortable currently with this level of pain medication. Can you maybe suggest a way to improve her comfort if we don't increase her medication? The other thing to do is, because I find a lot of physicians, as you say, just don't know what to do or aren't comfortable increasing medication, right? And suppose you give a dose, or you give a suggested dose, and the doctor says no, and gives you a dose, like say instead of giving you the 50 milligram dose for Mrs. whatever, he says, well, let's raise it from 35 to 40. And you think, oh, damn, that's not going to do any good, right? You could say, oh, Dr. So-and-so, do you have concerns about raising her morphine dose? Or, Dr. So-and-so, I'm not sure that will make a difference. That, studies say you're supposed to raise the dose by at least 25% to have a positive effect on pain that's out of control. Strategies like that might help, because I think you're sort of gently reminding the physician that they're not solving the problem and that this is a significant problem for the patient. Now, you mentioned what to do if they say Demerol or something.
Right, and give you another medication that isn't appropriate.
And would that be because they're afraid of raising the dose?
No, it could be because they have no knowledge about palliative care and about the use of Demerol.
Yeah.
I've had that happen where a doctor wanted to order Demerol, or not morphine or Dilaudid.
And you could say, that's where I think symptom management guidelines come in extremely handy, right? Because you can say, well, I've heard that medication is not the best to use in pain management. Can I send some guidelines to you? I think that would be okay. Physicians, yes, they may get their knickers in a knot over that, but, sending them guidelines and sending them papers can be very helpful, because I think doctors have to face medical literature when it's presented to them, because you're speaking their language. And I think any physician who doesn't know about evidence-based medicine now, must have been in a time warp for the past 10 years. So I think that can be helpful.
Okay. I think that we need to probably move on so that we can get questions from the participants.
Mm-hmm.
So first of all, I wanted to mention the questions that were actually written on the registration form. Mm-hmm. One of them, the first one is from Andrea Ho from Vernon. She says, what do you do when physicians refuse to order appropriate medications and the patient is suffering and there is no palliative physician consultation in the area at home or freestanding hospice? I think we might have addressed that already.
Yeah, I think so, with using symptom management guidelines, and actually Vernon's in Interior Health, so they have their guidelines. I also think to sort of say to the physician, I think Mrs. So-and-so is really suffering, and I know we both want her to be comfortable. What can we do? And, then I think the physician is going to be put on the spot and challenged in a nice way that they have to do something about this. And you can always suggest, if you're not in British Columbia, if you're in BC, you can call our 1-800 line. If you're outside of BC, suggest that they might call a palliative care unit in one of the cities to ask for some help.
Okay. I think we still need to move on here. How can home care nurses empower palliative patients in their relationships with GPs who tell them they will only deal with one problem, issue, need per appointment, therefore forcing multiple appointments? This is from Elaine Kilms from Parkville, BC.
Right. The way around that, I would say, is that most physicians will have times of day in which they can make longer appointments. And what may be happening is that the patient says, oh, I won't be very long, but I just really need to see them today. And then they come in and they have about 5 problems instead of 1. I think the thing is to phone up and say, I need to spend some time with Dr. So-and-so, and I'd like to book a longer appointment because I have a number of issues to discuss. Can Dr. So-and-so make me an appointment when he or she has got the time to spend with me? And giving the doctor a few days' notice at least will be helpful. I used to schedule end-of-the-day appointments, the people where I could sit down and we could discuss the difficult things. And if they gave me advance warning, I can do that.
I want to be able to open it up for discussion.
Oh, hi. Yeah, this is a question for Dr. Gallagher. She had referred to a 1-800 number in which staff could call for advice or suggestions around pain management or other issues. I'm just wondering if that 1-800 would be available to us in Manitoba.
If you paid us, yes. No, it's only available actually in British Columbia, and we did have it available in the Yukon too as well.
Okay.
So unfortunately, what I understand happens in Manitoba is that you call the Winnipeg Regional Health Authority Palliative Care team there, and they would encourage your phone calls, because I think that's what you should do, because then you could say, I spoke with Dr. So-and-so. When you're dealing with a difficult physician, I spoke with Dr. So-and-so and they suggested it. And what the nurses have told me in BC is that often they say, I've spoken with Dr. So-and-so of the 1-800 line and they suggested this. And the doctors will often just go with that.
Okay, thank you.
Thank you.
I think our question was the same as to how we could get symptom management guidelines.
There are a number of online manuals, actually. And I think they can be extremely useful in, referring physicians to that. Hopefully most physicians are becoming internet savvy and would use that. I think a lot of them do. Hi, Elaine.
Hi. Listen, I really liked your comment about nurses developing trust with physicians in terms of getting orders. The other point I'd like to make about that is that goes both ways, is that physicians need to earn nurses' trust as well in terms of knowing the drugs and being responsive to the requests for orders.
Elaine, do you mean that physicians need to learn to trust
I think
nurses?
Well, I think that that physicians need to earn nurses' trust as well. Mm-hmm. Because there's a lot of very, very proficient nurses out there who really know what they're doing, and certainly they have a list of doctors that are more responsive than others, and it really makes for good teamwork when everybody can work together and trust each other.
I know, and I always considered the home care nurse to be a wonderful help to me, and I only wish that I could convince physicians that some physicians that is the case. As I say, I think this is some physicians who take this responsibility of being responsible for another profession, and they take it to the nth degree, and it's ridiculous, because I think it ends up having a negative impact on their patient, and that's where I think if the nurse says, but here's the impact this is having on the patient, what would you suggest we do about this?
Absolutely, I agree, and that certainly works.
Oh, hi, Romayne. I just wanted to mention the Canadian Virtual Hospice website as another resource for people in terms, for patients and families, but also for professional caregivers. There's spots there on the bulletin board where you can ask questions about a variety of different topics and get very professional answers back.
Oh, thanks.
I hope you've all tried out Canadian Virtual Hospice, and it's www.virtualhospice.ca, isn't it, I believe. And they have, you can even post questions there that will be answered by the folks in Winnipeg, and that can be extremely helpful for people. One more comment about what to do when you really can't stand the physician and you're so bloody frustrated with them. And I think this was on a good conflict website person, is to, when you're phoning up and you're thinking, I've really been frustrated with this doctor before, is to separate the people from the problem. And when you're making the phone call, to think of something good about that physician, something that they're committed to their practice, they're willing to go see patients, and keep that in mind, because that really, your voice will be friendlier, you'll be more relaxed, and you're more likely to succeed. And that's how you start to build trust with people that just frustrate the hell out of you. And I can, I only wish I could learn that as well as I could say it.
Thank you, Romayne. I'd like to thank you for joining us and sharing with us the importance of team and strategies for working within a team effectively.
This has been a Pallium Project Professional Development Podcast. For more information on the Pallium Project, including written transcripts of this session, please visit www.pallium.ca. Pallium.